Again, thank you. It's been such a great morning. I hope you feel really excited. I am going to get us moving into our next panel, a plenary panel presentation, before our break for lunch and our film presentation. So again, I'm Dr. Olga Costa-Price. I have the honor of introducing our moderator for this panel on regional perspectives on Latino health. I'm not sure, Uma, who has slides, but I think they're in sequence. Okay, terrific. And I think Uma will introduce or have her panelists introduce themselves. But I would like to introduce my friend and colleague, Uma Ahluwalia, who is the director of Montgomery County Department of Health and Human Services. Ms. Ahluwalia, she oversees one of the largest Montgomery County government agencies with nearly 1,600 employees who provide programs across a spectrum, such as behavioral health and crisis services, children, youth, and family services, public health services, and special needs housing, among others. Her career spans 24 years in human services, I know. 27? Okay, her bio's not up to date. Getting older, but her passion and her commitment to this region and her work is unprecedented. We just are pleased and honored to have you here moderating this session. Certainly, please take a look at her bio, but without ado, I'd like to welcome Uma. Thank you.
So good morning, everyone. We have an amazing panel today, so their wisdom is going to be really helpful, I think, as we inform the agenda that we have around Latino health disparities. What I did want to do a little bit before I have the panelists introduce themselves is to set the context for what are health disparities and why is this such an important conversation for us to have. So if you would bear with me, I won't take long because we really want to hear from them. The World Health Organization, said that improving the health status of the region's residents and reducing health disparities requires addressing social and economic determinants of health. So really the conversation today is to talk about SDOH. Why is it that impacts health outcomes? And how 3 communities across the region are responding to this issue. So here are some of those elements that are considered to be social determinants of health, Economic stability, social community context, health and healthcare, neighborhood and built environments, and education. We have the same conversation on the education side, What are the social determinants that impact the educational achievement gap? So here we're going to talk about health disparities today. So here are the communities that make up the COG region. And what dropped away were the percentages, I think. So look here, Washington, we had a really good conversation earlier from a demographer who really talked about foreign-born residents. I can speak to Montgomery County. I saw that in Fairfax as well. We're at about 33% foreign-born immigrants for Montgomery County from all over the world. That's pretty large, Our school system has over 160 languages that are spoken. So this issue of language access, and we're going to talk about service delivery, how complicated it becomes to understand the cultural nuances. It's not just cultural competency anymore. We're really having conversations about equity and social justice. It isn't just about language access. It's also about, and somebody said, it's not just about being insured. It's having the health literacy to know what to do with the insurance that you have. So it's all of these conversations at the same time. So this was, I thought, really important, Understanding the youth population versus the adult population, because a lot of the conversation in our communities focus on positive youth development efforts. And how do you make sure that young people, not just their parents, not just their grandparents, but young people are also getting access to the care that's necessary? And you see the breakdown over there by population. And interestingly enough, some of the communities that we're talking about today have large numbers of young folks that we need to pay attention to. Educational achievement. All these factors have an impact, So when you look at who has a bachelor's degree and who has a high school degree or less, and the communities that folks are coming from, who live in our neighborhoods, in our communities, These are the folks we need to care about the most. If you have a high school diploma or less, how are you going to get to financial stability and how are you going to access healthcare? I always, we have in our community over 20% of the folks who are living in our homeless shelters are under 24 years of age, single mom, 1 or 2 kids under the age of 5 with a GED or less education. How are we going to get them in our unaffordable communities, get them to financial stability? Is healthcare the first thing on their mind, or is it putting food on the table? And is it the $2 McDonald's meal that's going to be what drives them, or is it healthy food options? Even if WIC can be taken to farmers markets, is it enough? Are families actually going to make it there? If they're working 2 and 3 jobs, where's the time to cook healthy options at home, right? To think about the homeless diabetic, what is she thinking about? Her health care or finding a roof over her head that night? These are all important questions for us to wrestle with. Chart of child poverty, such an important indicator of what's happening in our community. And where do we see child poverty at its highest? All of our communities are impacted by child poverty. None of us are exempt from it. When Mr. Troll said Montgomery County is awash in resources, I'm thinking not so much. Not nearly enough to meet the needs of our community. I can remember when I came begging to Kaiser saying, cover our children, they are uninsured. We don't have the resources to do it. Help us out, right? It's the story of all of our lives. We're all struggling to put the resources together. If healthcare is a right, then definitely our children and our adults should be covered. So I just wanted to set that context, a little bit of the social indicators that impact healthcare and healthcare access and health outcomes. And we have a fabulous panel. I'm just going to do a quick round and have Penny and Christian and Sonia introduce themselves, if you wouldn't mind.
Sure. Good morning. I'm Penny Gross, Fairfax County Board of Supervisors. I am the vice chair, and I chaired the Metropolitan Washington Council of Governments in 2009.
Good afternoon. My name is Christian Barrera, and I serve as the Senior Policy Advisor for Health Policy to the Deputy Mayor for Health and Human Services. She's really sorry she couldn't make it today, so here I am.
Buenos días. My name is Sonia Mora. I have the pleasure of working for the Montgomery County Department of Health and Human Services, where Uma is my boss. So it is an honor to...
She has to say only nice things now. Great. Well, thank you all. So we have a few questions that we worked up, pulled together, and actually gave to our panelists so they could prepare for this, which will make it a much more useful conversation, I think. So we'll go around and have a conversation, and it's going to be fairly informal. So at some point, we'll stop and have Q&A at the end of it. So I think the first question that we wanted to spend a little time on is to describe for panelists, and maybe Penny, we could start with you and go down this time. Describe how you're integrating social determinants with health services and policy to improve the health of Latinos living in your community.
Well, thank you very much. And I must say at the beginning, the other 2 panelists are the experts. I'm an elected official who has policy-making authority, but not necessarily the deliverables. And so I imagine that the other panelists will have a lot more in-depth information for you. But let me just talk a little bit about what we find in Fairfax County. And before I get into that, I need to mention that 16% of the population of Fairfax County, about 183,000 people, are Latino. Interestingly, our school system is 187,000 students. So we've got, a school system about the same size as our whole Latino population. And of those individuals, about 20%, 20,000, slightly about 10% live in poverty. Geographically, the largest number of Hispanic and Latino residents in Fairfax County live in my district, in Annandale, Seven Corners, Bailey's Crossroads, and in the Falls Church portion of Fairfax County. So over the last 21 years that I've been in office, I've seen the population grow, but it was never small. And in my term of office, we have always had a robust and vibrant Latino population. In Fairfax County, as in other places, Latino populations have the lowest median wage by race and ethnicity of all racial and ethnic groups. They earn the lowest wages of any demographic group in Fairfax at almost every level of education. And as I mentioned, immigrant Latino children have the highest rates of poverty of any group of children in the county. We recently completed a very robust human services community needs assessment that shows, and these are some of the top things, behavioral health is an arena where significant needs are apparent, with many barriers to individuals for trying to access both outpatient services as well as residential treatment. That's an issue for everybody, not just for the Latino community. But you can imagine if behavioral health barriers are present in the community for a well-educated Caucasian, let's say, for somebody who is struggling in their family and has behavioral health issues, it's going to be many times more difficult for them to figure it out. That's why we did this human services needs assessment. For Hispanic and Latino populations, there are significant barriers with respect to language access, cultural conceptions of illness, and social stigma. And I want to talk a little bit about the cultural competency piece that we need to make sure we have, and we are striving to make sure we have in Fairfax County. Providers and policymakers need to have and understand those cultural competencies. In our Latino population, we have folks from all over the Latin American hemisphere. They all have a fairly standard language, which is where we lump them, but we fail to look at where the countries are that they may have come from. And so when you look at the political issues in some countries and the cultural issues that go way, way back, you need to have an appreciation of that. The providers need to understand that. You might not you might handle somebody from Bolivia differently than someone from El Salvador. You may not want to put Guatemalans and Hondurans together at some times because of various issues. And I'm sorry, I'm not as competent in all of the political geography as I should be, but it's something that when you have, it's a little bit like the Washington Redskins and the Dallas Cowboys. You put somebody like that together and you're not going to necessarily have a pleasant outcome. So we have to be aware of that. We also have established we understand that in order to be truly effective, we have to go beyond the traditional provision of services and begin to address root causes and social determinants with a strong focus on community capacity building. And so government must embrace the diversity of our community. Actually, there are some governments who fight against it. Not a good idea. It's so much better when we can work together. And we must leverage the community assets and the building capacity to deliver culturally and linguistically appropriate services. That's what we're doing in Fairfax County. That is part of what we did in the Human Services Community Needs Assessment, and we actually have other reports that we've done back as far as 1999 that help us put together what we do today. So with that, I think I'll stop.
Okay, thank you. Christian, do you want to, as you take on the first question, sort of in terms of social determinants, can you also talk about it in the context of who are your partners who are public and private as you do the work?
Absolutely. And in full disclosure, I want to say that I am Salvadorian. I came here as a young immigrant with my family, so it is really great to see this sort of event where the focus is on health equity. And I like that because it implies that it goes beyond health, right? Healthcare or access in the community goes to the social determinants, housing, employment, education, all these really integral components of someone's health. We recently started seeing more research along the lines of housing equals health. And for those of us who are in the public health field, it is a really exciting opportunity to start reaching out and talking to agencies and departments that traditionally haven't seen themselves playing a role in health. And so thank you so much for organizing this today. So in the District of Columbia, we have about 637,000 residents. So compared to our sister jurisdictions, I think we might be slightly smaller. But that doesn't necessarily mean that when you look at, the health disparities as a population as a whole, that we aren't seeing disparities across ethnic groups and racial groups. Actually, as a whole, the district is really sort of on a good trajectory towards promoting and achieving health equity. Currently, we have about 54,000 folks who are of Latino or Hispanic background. And most of them are actually Salvadorian, 30%. So my country has a really great representation, I think, in Montgomery County and also here in the District of Columbia. And so when you think along the lines, and I really like what Uma just said and what Penny also mentioned, that, you know, being a welcoming community toward immigrants is not just, you know, doesn't just increase the diversity of that population, but also benefits everybody. And so in the district, what we're currently struggling with is really a housing affordability crisis. And so, and I'll talk more about later as, you know, we dive into sort of like what type of services and investments need to be made, not just in the immigrant community, but in our region, so that, you know, that we can invest in affordable housing. But something that I also, in just giving you guys a little bit more of sort of like the demographics and educational statistics and all of that sort in the district, 60, in terms of education, we have 41% of our Latinos in the district who are 25 years or older have less than a high school diploma. That's 41%, pretty high. We also see, but when you compare, though, I think we see a slightly different trend here because we also have 24% who have a bachelor's degree or higher. So we need to figure out what's going on in the middle right there. In terms of housing, 65% of Latino-headed households in the district rent rather than own their homes. And I could go into a lot of the history of our neighborhoods here in the district. And there are Latinos. Latinos are in each of the 8 wards of the District of Columbia. We have 8 wards. We're everywhere. But you also will find out that we tend to concentrate in certain areas. So wards 1, wards 2, and wards 4, you will see a higher ratio of the population being Latino. Now, what happens in those neighborhoods is very interesting because a lot of what happens in terms of housing over there, and you'll hear if you stay later from Mikasa's executive director about what we're doing in terms of affordable housing, but you know, we don't really have the higher ratio of homes. We have a lot of townhouses. And so as we're looking at the housing boom and all these other things, I think that some of the considerations that we need to start thinking about is how are our cities investing in development projects where you elect officials who negotiate on your behalf to ensure that, you know, we keep affordable housing units. And I think that that's a very critical thing to think about. Most people will say, yeah, you know, we're putting a target here, we're putting that there. Well, how are they contributing to the larger community in terms of, or, you know, we're developing this gigantic building right here. So how are those folks, the developers, contributing? So, sorry, I just went on a tangent.
No, thank you. It's all helpful. Very helpful. Sonia, do you when you talk about the construct of sort of what we're doing to address social determinants, can you also spend a little time talking about who are the public-private partners that we're working with, and also sort of some examples, if you will, of successful partnerships, and then we can loop back and have some of those follow-up conversations with others.
Well, thank you. The whole topic of social determinants, in a way, in terms of history and public health, is sort of a new topic. And we've been hearing about it maybe in the past, 7 years, 5 years or so. And everybody understands the concept of what it is and how it affects health. But I think where it becomes more difficult is how do you actually address those social determinants and integrate them into your practice, into your programs, into your policies. Right? That's where the rubber meets the road, and that's where I think a lot of people are having some difficulty. So for me, and the way I'm going to talk about this is mainly from the experience, the work that we do in Montgomery County. And I can talk about it from a more macro level, and macro for me is within the department where I work, very large department, 1,600 employees, over 500 programs, and we have a lot of partners that deliver services for us. But one of the things that occurred, to give you a little bit of history, in 1990, in our county, the administration back then decided to bring together several departments. And so we brought in public health. We have an aging and disability services, children, youth, and families, special needs housing, public health, and we all became one department But the difficulty in this was, how do we integrate? How do we bring all these different departments come together and begin some type of integration so that we can be a seamless provider of services where clients can actually come in, and one client is not going to have to go every time they go to a different program, tell their story, and be asking again the same questions, and perhaps not have a comprehensive assessment of needs and services. And I think, and not just because she's here, but this is really true, Uma has been working with us for the past 10 years, where I think the main purpose of her coming to us was to build an integrated department. And that's what we have been doing for all these past years. It's been a real struggle, I think, at times. And a lot of people who have been there in the department, I've worked there for 26 years, we were not really sure what it meant. But we have come a long way. And some of it deals with the whole integration of technology. Some of it is how do we do integrated case management between different service areas? How do we have a health record that is unified for all of us? How do we streamline our points of access where people come into the department and then if they're coming at an HIV clinic, but they also need special needs housing or they need other kind of services, we're going to have one place where we're going to be able to look at all those needs and be able to refer people in a way that is concrete. So that is important because the department is providing services, as we mentioned, on other issues. People that need housing, people that need cash assistance, people that need to be connected to employment. So that's a really critical piece, I think, on how we are in practice beginning to address social determinants at that client level. And we are beginning to see progress. With the IT integration piece, I think it's important also because we have data that we never had. So we're going to be able to really understand what the concrete needs and the progress that we're making with our clients. And that is an important tool to have to be able to do planning and to find out where are the biggest needs. The other advantage of what we're doing and having this integration is that we're able to leverage the resources that we have, right? So if somebody, for example, comes into a program, and this is actually occurring, where they're coming for a particular service and we find out maybe that person is an internationally trained health professional. That's one of the programs that I happen to manage. Then these people can get a referral immediately to us, and then we're able to connect them with our program to integrate them into the health workforce. But when we're doing also case management for these individuals, if they need any type of service, any type of social service, we're able to leverage that. So I think as a department, we've been very proactive and moving. There are several programs in our department that have very strong collaborations with other departments. A key partner that we have in HHS is the school. The Montgomery County Public School System is critical for us. And I know that we have several collaborations, our linkages to learning program, the whole issue of closing the achievement gap for MCPS. They couldn't do a lot of the work and services if they didn't have the connection working with us. I know that we've been working also with police department to enhance their capacity to respond to behavioral health crises. And so all this integration has happened really at a wonderful level. The other part that I think is important to mention is our Healthy Montgomery effort, which brings together everybody in the community, hospitals, service providers, legislators, community members, and actually to develop a plan of action to improve the health of our population, and obviously that includes Latinos. And one of the things that I was very happy to see recently is that one of the priorities is going to be the inclusion of health in all policies. So we're just starting to work. I'm going to be part of that work group that is going to begin to craft what does that mean, and how are we going to position ourselves and position health so that at the policy level, when they're talking about transportation, when they're talking about housing, we have the health lens included in there. So I think I'm going to stop at that, Uma, because maybe later I can talk about what we do at the Latino Health Initiative, but this is just to give you a sense of what we're doing.
Okay. So, Christian, I'm going to ask you, talk some about the public-private partnerships that have There's this question of leverage that Sonia spoke to, right? Not all of the resources can come from government. Not all of the resources can come from the health department.
That's true.
So what are those partnerships and how have they worked? And if you could take a couple of minutes to answer that question, we'll go around and do another round and then leave about 5 or so minutes for questions. I think it will be helpful.
Sure. And just to brag a little, we are also doing a health in all policies approach, and we just last year created and established an Office on Health Equity within the Department of Health that is going to be doing that across government. So I'm really excited about that. Partners that truly help us get the ball rolling. We partner with universities. I think that folks like here at the George Washington University, the Milken Institute, continue to be great partners with us. We have a age-friendly DC initiative in the district that is looking at how we can improve policies for those folks that are getting older across all populations. We also partner with private think tanks. DC Appleseed has been helping us recently developing our HIV/AIDS strategic plan for the District of Columbia as well. The providers are really, really critical partners in the type of care that we want to deliver in the districts, as well as envisioning where things need to go. We're very proud to have Mary Center, La Clínica del Pueblo here in Washington, D.C., who are really, really strong advocates for the Latino community. I really, really admire Maria's work around child and maternal health and open them just a broad of opportunities for the Latino community here. And we do talk about the private and public partnership, but I do want to emphasize that, in government, we can be really great at working together, but we can also be really bad at it. And so sometimes we tend to work in silos. And just like Sonia was saying, that integration piece is really critical, because here you might have a provider that, is charging you, and I'm not saying that's a bad thing, but charging you more for the same service. And here's another provider that perhaps is producing more outcomes. But coming together and understanding where we're touching families across the system is a really, really helpful measure. We are also currently working with, COG is also a partner regionally. And so those are some of the few partners that I can think of right now. But there are many, many more I know in the community that we work with.
Super, thanks. Penny, I think you have some interesting insights into the work in Fairfax.
Yes, thank you. I wanted to especially talk a little bit about partnerships, because we couldn't do all we do in Fairfax County without the participation of our nonprofit partners and our various volunteers. But we in Fairfax County adopted a One Fairfax resolution back in July in partnership with our school system. And that directs the development of a racial and social equity policy to ensure all individuals in Fairfax have an opportunity to reach their highest level of personal achievement. Oh, that sounds like, interesting language. But what our chairman has said, it actually will help shape decisions regarding education, land use, zoning, and public-private partnerships. Now, some of those public-private partnerships that we already do in Fairfax County, our Department of Neighborhood and Community Services sponsors a Culmore free parent workshop. It's designed to help Latino parents understand their role in helping their children succeed in school. The health department has both a multicultural advisory council and an outreach unit. They do some of that same work. Then there are place-based initiatives like Opportunity Neighborhoods, and the Office for Women has something called Mujeres Transformando Vidas, which is a domestic violence prevention program. And then we have, just in my district alone, the Muirfield Clinic, which is just such a fabulous opportunity. People came together, said, we want to provide free service. We want to find a medical home. They operate out of a church 1 day a week. They serve people who otherwise would not be served. We have Just Neighbors. We have the Legal Aid Justice Center. These are all people I work with all the time. Wesley Housing, the Annandale Christian Community for Action, the parent liaisons at the public schools, and Inova Health Systems. The Inova Cares clinics last year served 11,500 individuals in multiple appointments, and 8,200 of those were Spanish-speaking folks. So that's just some of the partnerships that whose tentacles are out there in the community. It's fascinating to find out who's connected to something you didn't know that they were connected to that group, and then they're connected to that group. And it's really a wonderful integration. It's a wonderful tapestry of services and outlooks. Thank you.
Super. Sonia, do you want to speak to the issue of public-private partnerships as well, as it, in terms of your experience from the Latino Health Initiative and the work that you are doing?
Sure. I mean, there's just no way that in this time you could do work by yourself. If you are, you're not doing a good job as far as I'm concerned. Latino Health Initiative is one of the, I would say, considering the department, the newest program. We've been around for about 15 years, and it was conceptualized with a whole partnership model where we bring in the Department of Health and Human Services, people such as myself who work there, and community partners to develop a common agenda for Latinos in Montgomery County. So we have a steering committee that's composed of about 70 members that work at the national, state, and local level, people like Maria Gomez, who happens to be one of my co-chairs, and other individuals that are working in the field. And what we have been doing is, in the past years, we did the first needs assessment of Latino health in Montgomery County about 12 years ago. We are now going into our third assessment, and as a result of the assessment, where we brought in together community partners that included the steering committee, the representatives, people who are being serviced by the department or other entities, as well as our own stakeholders in our own department and other places in the county. We developed what is called Blueprint for Latino Health in Montgomery County. Our new blueprint, which UMA has not even seen yet, is going to be coming out in about a month or so. And that, what it does, it poses all the particular needs, what are the assets, and identifies priority areas for policy change in Montgomery County to change Latino health. So at that level, it's part of what we're doing. But at the program level, and I happen to have about 8 programs that I'm managing, and they're all targeting the Latino community in a culturally and linguistically competent way. We use health promoters, we use navigators. It's a new program that we're doing. And one of the key programs that we're currently doing is the family reunification services. And when we were talking about, I was looking at all these statistics, and I was saying we live this every single day. So we bring in families that are, and this is where the partnership comes in, are being referred by the Montgomery County Public Schools. What we do is we work in conjunction with them to ensure that we're able to help these children enroll into the Montgomery County public system. Before a child goes into in front of a judge, it is essential that they have legal representation and that they are enrolled in the school system. So part of the work that we do with the schools is we help the children to enroll, but at the same time we help them navigate services, and we have partnerships with legal services, which, by the way, are difficult to find. But we work with them, we navigate the children and the families to get legal services as well, and we connect them to healthcare services. And in Montgomery County, we're very fortunate. For those individuals who do not have documents, we have our own program. It's called Care for Kids, so that we're able to enroll any child that doesn't qualify for insurance anywhere else. So that's a big program that we have, and it's in conjunction, again, with the schools, the legal system, in our own health department. But in addition, what we're doing right now is doing reunification sessions to address trauma for these families. So what we have done is leverage partnerships also with internationally trained health professionals in our Welcome Back Center, which I mentioned before. And we bring these individuals. We have a core of 16 behavioral health professionals that have been trained, receive additional training on trauma, and to handle it in a culturally competent way, linguistically competent way, to help these families move. So I could speak here for a long time, I know, but I just wanted to give you a little bit of a flavor.
So We could go on. You can tell there's so much here. These folks have so much knowledge about what's happening in their communities. I have to tell you, many of you are aware that we had a Long Branch fire explosion a few weeks ago. It's almost been a month and a half now. And it brought to light how much the community does, how much government does, but how resilient our own community is and their own ability to access and navigate and take care of themselves. And if you put all three of those together, that's when you get to a place where families are well supported, right? They have to be equal participants and empowered to take advantage of everything that's available to them. And so this idea of education and support and empowerment has to be underlying all the conversation that we have. This paternalistic, we're here to help you, doesn't work. Families want to take care of themselves. And that's one of the early lessons that we have learned. And I think it's really important that we continue to invest in that value as we build systems and build collaborations. I know that I'm standing between you and lunch, but if there are maybe one or two questions for the panel members, we can entertain those if your hunger can stave off that long, right? It's a challenge for you as much as it is for me, yes?
I would like to understand the issues of chronic disease. As we know, those of us who work in public health understand the great concern that chronic disease is. And I would like to hear perhaps how we might be addressing that.
Sure. So the one thing we didn't actually talk about at all today was the impact of the Affordable Care Act on all of our communities, right? Yeah. We've seen a pretty significant expansion in folks who are insured. Does that necessarily? We also have large numbers of people who are not insured, don't get me wrong, and we have a pretty nice safety net of services. I know Penny talked about Inova and what they're offering. We have Montgomery Cares, Care for Kids, Maternity Partnership in Montgomery County. DC just has a Medicaid lookalike that's available for undocumented residents. And so there is, or uninsured residents, I should say. And so there is a lot of support. The question of how, and when Sonia mentioned Healthy Montgomery, one of the priorities in there is chronic diseases for us, a health priority out of our community health needs assessment, which is not atypical, right? Our Asian communities have it's similar chronic disease issues, as do African Americans, as do Latinos, but this issue of what is the culturally competent response to each community becomes extremely important. So I will lay that context. I don't know if any of our panel members want to respond to the question.
We mentioned the Montgomery Care System, I think we did earlier, this is unique to the county as well. It's a whole network, safety network of community clinics where people who do not have health insurance can come and be served, and they provide primary care services. And I know that they've been working very hard as well to be inclusive of the management of chronic diseases. For Latinos, a big issue, of course, is diabetes. And there are several of the programs in the Montgomery Cares Network that are not just looking at the clinical piece and the management, but they also have education. They've been working really hard to build partnerships with specialty care for the individuals that need it. And so that's wonderful. For me, the most important piece is the prevention. And when we have an obesity rate of 70% of Latinos are either overweight or obese, and they're at risk for all these chronic diseases, my particular program focuses a lot on prevention and well-being, and not in a medical model per se, but actually looking at the concept of wellness, eating healthy, exercising. That's where social determinants also come into play. You know, we've done research about why people are not exercising. It's the issue of not maybe having access to facilities, but also the safe neighborhoods, the lights, all that. That's part of what we need to be looking into more and more in the near future. But for me, prevention is really important.
If I may.
Neighborhoods are beyond just having sidewalks.
Yes, that's right.
Chronic disease is something that affects the entire community, not just a particular portion of the community. One of the things we've done in Fairfax County, and I want to talk to these folks over here because I've been focused over here and I keep forgetting there's folks over here. One of the things we've done recently is opened the Muirfield Clinic. That was a conglomeration of some county clinics right on the Inova Fairfax Hospital campus. It's a one-stop shop. You can walk in and you can get all sorts of services right there in one spot. I was sorry to lose the clinic from my district, but the Muirfield slot is only about a mile from the borders of my district. So that's making a huge impact already. In Virginia, we have a problem. The General Assembly will not expand Medicaid. They will not allow federal dollars to come into Virginia. Our governor has been very vocal on this. Many of us have been very vocal on this. It creates a problem for us in Virginia that probably Maryland and perhaps the District of Columbia don't have. Mm-hmm. So we are finding our workarounds to do what we need to do, finding people medical homes. The chronic disease piece is something, again, health and, what do we call it? Health and all? Policies. We've been working on chronic disease for a very long time. We probably will be continuing to work on it for a very long time. Our folks in the health department are great on this, but it is something. One of the things we've done in our park authority just this summer, we've installed in 2 low-income communities a playground that is exercise equipment for adults. It's pretty cool. One of them is in my district, and it was like going to the gym in the sunshine. And the kids loved it, but the kids aren't supposed to use it. It's for the adults. And you can you can walk over there and do 20 minutes of workout. Very easy. Those are the kinds of things. I think it cost us several $1,000s, but it wasn't a huge amount of money. Those are the kinds of things that make it easier for people to access their own exercise needs without having to pay for a gym membership. It's really pretty cool if you ever see one of those.
So, Christian, I'm gonna let you take the lead on the next question. We have one last question. That's it between you and lunch, right? Okay.
I also do want to brag that DC was one of the first. We consider ourselves a state, so we're everything, state, local, and everything. So to expand Medicaid, that has made a tremendous difference as we are working with the managed care organizations to coordinate care for district residents. And also, we have actually also recently we will be launching a new school health services program. To your point about partnership with the schools, which is integral. We found out that our students had tremendous health needs, asthma, chronic diseases, and so we are going to go to the schools. We're going to focus on working with those families and the students to ensure that their care is being managed. So that's going to be a tremendous shift in how we're doing and delivering school health services in the District of Columbia.
Great.
Hello. While realizing that the Latino identity and Hispanic identity is multifaceted, it can't be pinpointed to just one identity, I was wondering, in the work that is being done within your regions, we know that there is a hostile social justice, injustice, I should say, environment within the United States right now against immigrant populations, against the Latino population, as well as the Black community. And I was wondering if there was any foresight to look into the Afro-Latino identity and how that impacts the health equity within your communities.
That's actually a really, really great question. We have a mayor here in the district that always emphasizes being inclusive versus exclusive. And I think that that's the great thing about the policies that we put forth in the district. It's not just creating something that specifically is for one group, but rather how do we bring everyone under the same umbrella to ensure standardized services and the quality of the services. We have an Office of Latino Affairs that I'd like to connect you with to better answer that question, because I think that when you do look at the sort of like the demographics of the Latino population in DC, we do have folks who come from Panama, from Central America, South America. And so I don't know that we've distinguished in terms of services, in terms of like the Afro community, Afro-Latino community. But I do understand where you're coming from. Some of my best friends are Latinos, and so I think that there is a certain stigma here and there. And so I'd like to put you in contact with that office if I can, so that they can better answer that question for you. Yeah.
Great. So with that said, can we give the panelists a big hand?
And let's please also thank Uma for her wonderful facilitation. Thank you.
All right. Thanks, everybody. Enjoy the rest of the